we have bring in attendees as we go along?
I think the latter. I think the original way that I'd planned it when I was going to do the chairing bit, and obviously change it as you wish, would have been to just pose the questions, bring the panelists in individually as answers to those questions, and then when people put their hand up, sort of question time style.
Attendee, or that we have bring in attendees as we go along?
I think the latter. I think what's happened there? We're bouncing back on ourselves.
Yeah. We've got, are the attendees, the attendees aren't in yet, I take it, Dan? Dan? Dan's gone quiet.
Dan, can you hear us?
Dan? We've got, Dan, we've lost you.
He's doing a lot of frowning.
That's never a good thing.
Right, are you back? Are you back, Dan?
Yes, I am. Sorry, I was sorting out the live link. Yes, I'm back. How can I help?
The attendees are not in yet, presumably.
They are, yes. So they just, attendees have joined. We've got 35 who've joined. So we're rolling, essentially.
Okay, fine. Right. In that case, good morning, ladies and gentlemen. My name's Stephen Dorrell. This is a webinar organized by the World Healthcare Journal in collaboration with Public Policy Projects. And the purpose of the webinar is to look at the position on digital health, the development of the digital health infrastructure. As was, I think, helpfully said yesterday, it's time for us to move on from talking about digital health and just talk about health and the role that digital technology can play, is playing, and most importantly will play in the changing shape of healthcare provision. It's obviously true that not in Britain, but all around the world, actually, the COVID crisis is forcing the pace of change in healthcare services, and an important element in that change process is the development of the digital infrastructure to enable different ways of delivering healthcare services. And the theme of this morning's webinar is to explore with some panelists and with a wide range of people who've joined as attendees. We have my screen tells me a rising 70 attendees on this webinar to look at what is happening now so that we don't, it's not a future gazing exercise. Where is digital technology currently enabling the changing shape of healthcare services? Where are those changes most valuable, and how can we see that progressing, not in a 10-year term, but in a 1-year, 2-year, 3-year term, so that we can actually see the development of the changing shape of healthcare, taking advantage of digital technology. Those are the themes I want to explore in this webinar. We're very fortunate to have a range of panelists with us that I'm going to go to in the first instance to get the conversation going, to offer us their thoughts about, in answer, I think, to two key questions. Which elements of the digital package are being found to be most valuable in the context of COVID? Question one. Question two, what does that tell us about where the short-term opportunities, the overworked phrase of short-hanging fruit, where are the low-hanging fruit, where are the short-term opportunities, the low-hanging fruit to push forward with digitally led change over the next 1 year, 2 year, 3 year period? And I'm going to turn first to Hassan Chowdhury, who's an advisor to the Department of International Trade on the development of digital technology and ask him to summarize where he thinks digital technology is driving change now, and where are the greatest opportunities to take that forward in the short to medium term. Hassan Chowdhury, would you like to go first, please?
Thank you so much, Stephen, and to the whole team and my fellow panelists. I think the biggest challenge for us in digital health for many years was getting over the hump of adoption. How do we make the case for something that we, as CIOs, for example, would have been thinking, this is a no-brainer, we need this. And I think that hump has gone. Lots of people are now ready to take it. The problem here is there's too much noise. There's so many companies trying to make an offer that the good companies are being drowned out, sometimes by bigger companies or those who are able to offer a service for free for a while and distort the market. So the real opportunity here is to do things right, to find the companies that have got validation and evidence that can make an economic impact, a budget impact in the pathway, and to insert them into the pathway because they are the right solution, not in a crisis mode, not in a panic mode. And that requires some real thinking, some depth. I'll give you an example. Advising, who I think are a fantastic company, have done great stock checking at live, real time for personal protective equipment, PPE. Great example in Greater Manchester. Now, they were the right solution before the crisis. They were fantastic before the crisis, but it took the crisis for them to come forward and to be seen. And that's the example that I would like to highlight as what we should be doing.
Okay, that's a great start, Hassan. Thank you. I'm going to go round the rest of the panel with some sort of short introductions first. And I should say the house rules this morning are that this is an open webinar. There will be a record taken, and it will be used in order to hopefully develop further understanding of digital technology through the World Healthcare Journal and through a range of other publications and platforms that where we hope we can offer these insights. So I'm going to go next, please, to Nicola Haywood-Alexander, who is the Chief Information Officer in, I think I'm right in saying, it's Portsmouth, Nicola, but you'll remind me if I've got it. It's no.
No, I don't work for Portsmouth anymore, but I am a healthcare CIO, but I'm here in my capacity as the co-founder for Tech for CV19, which is a voluntary organisation that has come together to form a community across providers, enablers and users of health tech, not just in the health setting, but across the whole healthcare and welfare setting. Those of us that established this forum and this community were doing so really in a response to, as Hassan referred to, a lot of noise. That to some extent was quite overwhelming if you were a CIO or a digital lead within the current health setting and the crisis that was upon those colleagues. But also everybody was recognizing that there was some great offers out there, some real generosity. We say that, part of our well-being is our ability to feel needed and be able to contribute and offer. And I think that was a huge response in that regard. And we wanted to be able to provide a place virtually that people could come together with those offerings. And that grew very quickly, actually, from around 50 people on a WhatsApp group to we now have around 180 people in the community. And as I said, it's a spread. And we are now looking at how we can help to facilitate those offerings, help to present them in a way that it's useful to those people that may want to utilize them. And we're also looking at how we can validate them from a business sense, look for evidence to support them in their clinical effectiveness or their social care effectiveness. And I've seen some really fantastic examples of tech being offered, but you also asked about what was currently being put forward. Well, there's been obviously a real uptake around the virtual consultation area, and I'm not going to talk too much about that because Rachel is an expert in that particular product area. She's the CTO for one of those providers that's very active in that area now, very much so brought in to help with that because how much that was expanding as a result of COVID. But before I hand over to Rachel, I would like to point out that what I've also seen is some excellent opportunities to develop apps, or even apps that were already there, that help people at an individual level, that can help citizens that perhaps are finding life more challenging during these times due to isolation, due to not being able to connect with people, maybe not being able to get the access to their normal groups of support, therapists, for example. And there already was, but they didn't really have the take up that they'd had before. And I would like to see how we can promote these more. But a lot of apps that were using things based on gamification techniques or using things like avatars, very useful, and quite a number of them now are working with Orca to look at their clinical effectiveness. And I think because these are not taking very long for SMEs to put together, and they're being developed by some really great guys working with some clinicians who've got some wonderful ideas, and also therapists working in the community, that there is something we can do about trying to bring more attention to those applications and what they can do.
That's great, Nicola. Thank you very much. And I'm sorry to refer to your
It's all right.
previous role rather than your current role. But you've given a perfect segue to Rachel. So, Rachel, perhaps you better introduce yourself so that you get it right rather than me making a mistake.
Thank you.
You've been given a perfect introduction.
Yeah, so I'm also a former CIO. I run the NHS Digital Academy. I'm currently in Visionable scaling for COVID part-time, and also still doing research activity around digital health, which is probably a very good sort of lead into what you were talking about before and what Hassan was talking about, which is about evidence bases for what we do. For me, Nicola and I began this community with some colleagues because we wanted to create a space where people could be joined to solutions that had an evidence base. We're very much able to take an evidence base for the efficacy of digital health solutions. And indeed, by the Academy and Global Digital Exemplars, we had looked at the evidence for a number of digital health approaches and specific solutions in some cases. And what appeared to be happening was the system needed the knowledge quickly to find out who was in the system and who could adopt those technologies. And indeed, we had some of the smaller sort of companies that we had worked with who were unable to access perhaps the funding and the scale-up support that they needed to actually take solutions that were effectively working in the NHS and move them forward at scale and pace. So my interest here, I guess the two questions you asked, what has been most effective and how will we take those forward in the next 2 to 3 years? The most effective solutions are framed for me in a way where they allow the geography and the skill mix of care to change or be flexible. So delivering in or near the home, allowing the citizen to be part of their own care team, and allowing the skill mix to change so every contact counts with our citizens, and allowing the likes of video, remote apps and remote testing facilities to be available. And I really categorize those into those that support new models of care, which we previously have not been able to deliver, in part because of the commissioning sort of levers within our system, which I think will change rapidly now. And they, in turn, are things which we begun to gather a really good evidence base for. And so what I'm looking forward to in the next 2 to 3 years is a rapid gaining of evidence for the efficacy based on what we've done with COVID, but also an iterative sense of care redesign with technology as an enabler. So we just do talk about care and not digitally supported care, enabled care, because digital becomes one of our default platforms, just as hospitals and buildings have been in the past. We never used to talk about building provided care. So that's really my introduction.
Okay, and can I just pose a question, really, because I think it's a question that we need to explore in this webinar. It must be right, mustn't it, that the development of digital technology allows us to deliver more person-centered care. That was the phrase you used. It allows us to assemble around the individual citizen and patient a much bigger information base to allow the care to be well informed, and therefore to the care itself to be based on evidence. And I wonder how this has been a claim made for digital technology for some time now. Is that a theme that you think is that infrastructure? It's a form of kind of service infrastructure. Is that being given a big push by the COVID crisis? Can you think of examples of specific bits of digital technology which are allowing care to become more person-centered in real time?
I am, and I think I will first of all caveat this with a digital approach is not suitable for absolutely every citizen. So some work that I did around the renal pathway and renal failure showed that it was suitable for 80-something% to digital pathway. But there were some of our citizens that are digitally excluded. My dad, before he passed away, would have been a great example. He'd had 2 strokes, had issues with language and communication, and a face-to-face or supervised pathway with a carer was more suitable for him. In the renal example I talked about, we had to create 3 different pathways, one of which was digital pathway with 80-something% uptake. Another one was a traditional face-to-face pathway because people were not comfortable or able to uptake the digital. And the third version was a super intense version of the pathway, which took our patients with polypharmacy and comorbidities and provided preventative care there to stop them exacerbating or admitting. What we are going to find with these digital pathways is that we are going to need to work out how they apply to our populations. I think we've pushed really hard on this, and we've been working to increase the digital literacy of our populations just generally for shopping, for everything else in the COVID sense. But in its own sense, we will end up with diffuse pathways and using risk stratification. A very simple example I have seen are chatbots, which do ask people about their symptoms or about their existing conditions, or take those into account in the background, and then route people based on those. And I think that's a simple example where we're using what the patient tells us and what we know about the patient to create the right pathway of care. Indeed, certainly the work that I did at Salford, we would create risk stratification scores for sepsis, AKI, kidney injury, and other things that would play into choosing which variant of a pathway people would go on. So the early thinking's there. It's a long journey to go on, but indeed digital can help us to risk stratify individuals, but only really where we have clean, codified, real-time, reliable data about the patient, or they can give that to us as well. And so I would say we're still very early on that journey, but we do have the initial promising shoots of that being possible.
Okay, that's great. It's a theme to which we shall return, I suspect, in this conversation, is the availability of accurate, properly moderated data and from multiple sources. But let's make a note of that and come back to it. I'm going to go to Sam Shah and then to Steve Gardner, who's the publisher of World Healthcare Journal. But let me go first to Sam Shah. And again, Sam, rather than tripping over myself, I'm going to ask you to introduce yourself so that we get that exactly right. Sam.
Morning, Stephen, and morning, everyone. And it's great to be here, and fantastic to hear from Hassan, Nicola, and Rachel, who have already listened to and learned so much. So I am a clinician still working in NHS, and I advise a number of organisations on digital health. I previously worked in the NHS, working on some national programmes on digital development. And at the moment, what I'm really seeing out there is something quite interesting around the use of digital health and technology, but not for the sake of technology, because people are really starting to think about the needs of users and citizens. So some of the things that we're currently seeing right now that people are benefiting from are those things that are helping citizens right now, things that we might later classify as mHealth or digital therapeutics, for example. We're seeing products that help patients as patients, not just as citizens, connect to health services. So here's examples of telehealth. And then we've got things that help individuals, perhaps in certain disease pathways, use technology to help them both manage their care themselves, but to connect to a clinician. So telemedicine might come into play there, where we've got examples of things that help people monitor and manage their symptoms. And then we've got those things that are helping clinicians. Clinical communication tools, for example, or other things that allow clinicians to better understand the needs of their citizens they're caring for and those that become their patients. And especially those situations where they might find it more difficult to work in their normal way. But of course, these things have been tactical. They've been put into a system with perhaps not necessarily the same research and evidence base we would naturally look for. And I'm really glad that Rachel very clearly and rightly mentioned the need to continue exploring the evidence. And also, Nicola mentioned the good work that ORCA are doing around evaluation and assurance of these products and services. Because whilst we might immediately release things that solve the friction for the user, what we haven't done is what we traditionally do in the same way, which is look for that evidence. So certainly in the short term, some of the other things we can do is work with our international partners to understand what are the problems that society is going to face and continue facing as a result of the current pandemic. What problems clinically are stored up in the population that we need to manage in a different way? And how do we collate the research and the evidence, not only of the diseases that people face, but also of the efficacy of the products that are out there? One of the issues here in the short term is where we do have products that might appear to be free. What's the impact of it? Where's the data going? How good are they? What's the impact on the rest of the market? And how sustainable are they? And these are some of the things we have to deal with, because whilst in the short term they may appear to solve a problem, what longer term problem are we storing up? And are some of these tactical things really of benefit? Now, of course, there are lots of things that technology could solve for and that we could have implemented with the gift of hindsight. But of course, we don't have hindsight here, and we've got to work in the now. And so based on the problems that people face, and focusing on the problems that citizens as users of services face right now, we need to think about how we move to democratization of healthcare, how we move the control back to the individual so they can manage their care for themselves the best they can, where they can. And how does that help alleviate burden on the system overall? So those that can't use digital technology, those that have greater needs, can still be managed by clinicians and people going into physical services. And it's that balance that we need to look for. So the power of data will help us, but the global pandemic has probably done one thing: accelerated our need to respond to diseases. And some of the things we need to think about in the short term is what are the economic impacts of this on inequalities around people, and not just health inequalities, societal inequalities, and how will they manifest in disease? And for diseases, which technology solutions will help us? And the thing I pushed for is how we keep on solving the problems for individuals and pass back control to the citizen whilst helping clinicians reduce burdens.
Okay, Sam, thank you. Before I go to Steve, let me just pick up your phrase, the democratization of healthcare, which is a challenging phrase. I think by that you mean person-centered care, the greater ability for the patient and the citizen to manage their own care, and to provided, of course, that we address the need to ensure that's available to everyone and it doesn't exacerbate health inequalities. But the ability for patients to deliver, to engage in well-evidenced, supported care changes the relationship between the patient and the clinician, doesn't it? And I wonder whether that you feel that has changed during the COVID crisis in a way that's positive, negative. How has the relationship changed with the clinician over the last couple of months?
I'm certainly noticing from the people I deal with that they are much more in tune with what it is that they might need and want, and they're looking things up. And I think that's right. Now, of course, that puts a new burden on clinicians. We have to deal with new data that we're faced with. But I do think it's right that citizens are in control of their destiny, and that we provide them, not with empowerment, with agency, that they take control, and we are working for them to provide them with the healthcare services that will help solve whatever they're presenting with. And if we continue doing this, hopefully some of that care will move from being controlled by us to being far more patient and citizen-centric, so that people can then take far more control, but also manage those things, which in the longer term is better for everyone. Now, that comes with its own issues. What do I do with the gap in between, where I'm dealing with the demand of certain citizens right now, but also those that have got new demands, where they move from dealing with an illness service to one where they're looking for wellness? And that creates a bit of a block in the system, because of course we don't have the capacity. But ultimately we do have to move to a system which is patient-centric, where the data is controlled. And if those individuals control their own data and the state operates as a pseudo-regulator, then products and services, apps and other things can evolve that can build off that citizen data, that can work in a way that it combines itself with what citizen controls and owns. But right now we haven't got there. And that's why I'm really keen on what Rachel mentioned about evidence earlier, what Nicola mentioned about the assurance of products, and Hassan picked up on around some of those free products out there that may not really truly meet the needs of the citizen, but are designed around the system.
Okay, thank you. Again, the phrase agency on the part of the patient or the citizen is part of the key to this, I think. But anyway, Steve, my colleague, Steve Gardner, who is also responsible for the World Healthcare Journal partner in this webinar. Steve.
Thanks, Stephen. Thanks, everyone. I think, so we're coming back to these two questions that you asked at the beginning of the conversation in terms of what's effective and what we're going to see over the next couple of years. I think what's most effective, or what will be most effective going forward, and probably in many ways the question in my mind that is most pertinent, is how we join all of this stuff up. Because if you think about it, and Hassan and I have been working for the last year or so on a book called How to Digitize Your Health System. And as part of that piece of work, what we tried to do is draft out the patient journey, if you like, or the citizen journey rather, in terms of how we experience and how we encounter healthcare at what steps. And I think one thing in the process of organizing this event that I found actually quite humbling is the fact that we have this huge diversity of brilliant ideas, great technologies, stuff that solves problems at every step of that journey. And the question now is, how do we join all the bits together? How do we standardize? One of the issues that I'm sure we'll cover over the course of this call is data, and how data flows from one area of the system to another. We've got all these brilliant ideas. How do we join them up? And in terms of, I think for me, what's really interesting about this moment in time, as unfortunate and horrible as this crisis has been, I feel like for us in the digital health sector, this is our industrial revolution. This is our moment. As a result of what's happening around the world, the profile of healthcare has clearly never been higher. And there is an understanding globally, not just in the UK, at government level and throughout, of the need to change the way in which we deliver healthcare, which comes back to that wonderful phrase that you used at the top of the conversation, which I think you stole from me actually, which is, there is no such thing as digital healthcare anymore. There is only healthcare. And healthcare by its very nature will have much greater digital element to it going forward. I think that's my key takeaway is this is our moment and we need to take it, and we need to use this opportunity to develop our digital healthcare and revolutionise the way in which we deliver healthcare forever.
Okay, thanks very much, Steve. You're quite right. You did offer me the phrase, there's no such thing as digital healthcare, and I steal with pride. The one angle, one element, a hugely important element of healthcare, particularly during lockdown, which hasn't yet featured in the conversation, but I think I hope is about to, is mental health. Elaine Boosfield is on the call. I understand her camera isn't working, which is to our disadvantage. But Elaine, you had indicated to Steve you wanted to come in from the mental health perspective. So can I ask you to make your point? You will need to unmute yourself or something. I think, does Dan unmute you?
Elaine, you can speak, but just unmute yourself on your computer now.
Unmute myself. Okay, I'm unmuted. Can you hear me okay?
We can hear you.
Oh, good. Sorry you can't see me. That's probably a good thing. Yes, so I think that phrase is right. Something that it's music to my ears, actually, because for many years working in the mental health field and trying to sort of push the fact that it is possible to deliver mental health services using technology was a bit like when we first started talking to people about it, they looked just like we'd got three heads. So it's quite, I think that's true. There is no such thing as digital healthcare. There is only healthcare. And that's the truth of it, because really the digital is just about a different way of delivery, isn't it? It's just a vehicle that we use to deliver. We still have to kind of have the same clinical governance. We still have to have all the same rules and procedures in place. We still have to deliver excellent care. It's just a different vehicle. And I think given sort of like the hat I'm wearing at the moment is an international hat, but I think given the kind of problems facing the world at the moment in terms of anxiety, depression, in terms of people feeling quite lost, in terms of people suffering more severe kind of mental health issues as well, that the only way we're going to ever possibly reach people is through digital transformation of mental health care. So for me, it's something I'd love to see the World Health Organization taking up. I'd like, it needs to be a sort of an international push, I think, in lots of ways. It's quite interesting for us, sort of delivering the way we deliver in the UK, that what the COVID crisis has taught us, the sort of issues that both young people and adults are in terms of like the symptomology, in terms of the issues they're presenting during this crisis. We've seen a huge rise comparing data in this period to data last year, in the same period last year. We've seen a huge rise in sleeplessness. We've seen a huge rise in anxiety. Worryingly, we've seen the small numbers, but it's still a 500% increase in young people talking about child sexual exploitation, which just goes to show you how important schools are in terms of keeping children safe. We've seen a huge rise in domestic violence. So some pretty worrying sort of social issues have come out of this for us. And we've got the data to which we're sharing with Public Health England. So in terms of like delivery of services, I think that digitally is something we should all be adopting. But taking sort of the lady who mentioned that digital doesn't work for everybody, it's the same with mental health care as well. You'll always need face-to-face services. They're always going to be critically important. And for me, the future isn't so much digital, it's blended, really. For me, it's a blended approach. I think that's what we should be talking about, is a blended approach. It's not one or the other, it's both together. So that would be my kind of take out of that, really.
Could I just ask you on the blended approach? I was on a call yesterday where I'm a trustee of Place to Be, which is a mental health services in schools.
Yeah.
And one of the points was being made there was that the blended approach, it's obviously gone heavily to digital in these circumstances, is that actually some aspects of mental health services, they feel as not merely as well delivered, but almost in some cases better delivered by using remote means. Is that your experience as well?
It is my experience. I'd say it is my experience. With digital, you actually reach people who wouldn't dream of accessing face-to-face services, maybe because of stigma, but also because when you're talking about historical trauma or when you're talking about anything that's shame-inducing, actually to write your experiences down, and actually the writing process itself allows people to sort of access parts of themselves, parts of their experience that they might find difficult to talk about face to face. So we find, and there's plenty of research to back this up, we find that delivering some mental health services digitally actually allows people to be far more open with their clinicians than they are face to face. I mean, in terms of our young people service, we've had children use our service who may well be in CAMHS, but who are mute, what they call mute patients. They just can't talk in a face-to-face setting. So they find that the digital space allows them to open up much more easily. So yes, so yeah, I think it's, but obviously there's other conditions like psychosis, which would be dangerous to work with just online. Things like eating disorders, you definitely need a physical care pathway for things like eating disorders. And also for, you know, sometimes that in terms of clinical depression and other such things, sometimes that human connection where you are sat in the same room with people is very, very powerful as well. So for me, it is very much about getting the right mix, really, offering people choice. I think choice has to be at the heart of everything we do. So.
Okay, that's great. Now, I suggest I don't go to every member of the panel to comment on every contribution, because otherwise we won't get through as many contributions as I would like to. But can I suggest that any member of the panel who wants to comment on a contribution signifies they want to do so by unmuting themselves, and I'll watch the panel stamps, the postage stamps on my screen. And if I see a panel member who's unmuted themselves, I'll ask them to come in to comment on the contribution. And Nicola has already unmuted herself, so there we go.
I was really pleased to hear Elaine talk about the blended approach. I spent 3 years working as a CIO with a mental health and social care trust, and during that time I did a lot of research into the benefits of blended healthcare and how we could combine both the physical and the digital pathways for a number of the reasons that Elaine has already pointed out. And prior to that, I worked in higher education. And higher education, interestingly, never talked about digital education, but it did talk about blended learning. And the blended learning was that combination between online virtual learning and then face-to-face learning and discovery and activity-based learning. That approach really sort of was catalyzed when the policy changed around higher education, and students started to pay for their funds themselves, which I think was a very interesting catalyst. It changed the whole funding model, and it actually enabled higher education establishments to quite easily review all their policies and their normal practices, so that they were focused around student journeys. And I think that is still part of our challenge here. So I think there's a correlation between taking a blended approach, focusing on the citizen, and actually changing our systems, our commissioning models, our ways of working, our norms in that same regard. Probably a little bit harder because there was a different policy emphasis that emerged in education that drove that through. And I'm not sure whether our current circumstances will have had that type of impact, but it's something for us to bear in mind. While I was doing my research around integrated care, I was fortunate enough to study citizens who volunteered through healthcare, through Healthwatch Sheffield, including families. And one of the families I'm keeping in touch with during this period, they were very happy to do that. Now, they were really taking a blended learning approach, because in this family, they have a child who is non-verbal Downs with learning disabilities. They have, the husband has type 1 diabetes. The grandfather has mobility issues. The grandmother has a chronic neurological condition. And mum tends to have to manage all of that. They also have different types of allowances available to them, personal allowances, benefits. The rules and regulations around those, as we know, are constantly changing. So we started to work with them on different types of technologies that would be helpful, so that they had that sort of blended approach to face-to-face clinical care, but also online support, online therapy. For example, a learning disability app that allowed her son to interact with very simple diagrams using Makaton to say if he wasn't feeling well, and if he wasn't feeling well, where the pain was, and for that information to be relayed directly to their GP. Now, this was all through Testbed. And what she was saying to me was, I really wish we had all those things up and properly running now, because this being isolated, because they are completely isolated as a family because of the situation they are in. She said, if I had all of those things actually fully integrated with this system, I would be finding this situation a lot less difficult. But in actual fact, what I really want to do is see those things up and running as an integrated part of the system anyway. And that gets me back, and I think I saw a question earlier about the challenge is that full integration between health services right through to social care services, right through to welfare, family services, etc. And because of the commissioning model, because of the devolution, because of outsourcing of certain services, that's become extraordinarily fragmented. And it may be that the blended approach can help us to address that fragmentation.
Okay, thank you very much. The question you were just posing about the fragmentation and a challenge, are we actually seeing the silos broken down? Guy Gross has raised that in his question. So if I may, I'll ask Guy to speak to that. In order to get some more contributions in before I go back to the panel, I'd also, Suzanne Shale has been challenging us around the extent to which the digital model does that lead to further problems of exclusion. So Guy and Suzanne, and could I also ask Nishant Nambiar to come in as well? So Guy first, Suzanne second, and Nishant third.
Hi, it's Guy. I work with Languison as a consultant, and we're looking very specifically at some of the challenges on really taking whole system approaches where silo A puts money in, silo B sees the benefit, and there's this cycle of never really wanting to take ownership and responsibility for whole system change as a system. Is there any signs that there is a central choice that they are willing to take a whole system approach rather than sort of buffering GP PCN level to say, you know, here's some money to do integration of communication with your care homes, which feels very much like just buffering the existing system rather than truly changing things and working out how to create integrated systems. I guess that's a general question for the panel.
Suzanne.
Hi. I think again, it's really a question from me, and I've quite often when we talk about digital inclusion or exclusion, there's a tendency to refer to older members of the community and say that there are some problems there. My experience has been not that older people are excluded from using digital technologies, because I've found that they've adapted quite quickly, but I think that there is a group of quite impoverished citizens who are not going to be able to access digital services. And one of my concerns is that if we don't plan for that from the beginning, particularly in the sort of commissioning process, that we end up not just excluding them from our digital offer, but because of the costs of providing for a smaller and more select group with face-to-face, that they're just going to get lost entirely. And I'd be really interested to hear the thoughts of the panel on that. Thank you.
Thank you. And Nishant.
Yeah. Hi, I think this was a good informative session for a person like me who has been in health informatics for more than 8 years now. And we have actually worked on some kind of an integration platform, because in healthcare, we always say that silos is a big problem. Integration is a challenge. Interoperability is another challenge. So we have already solved this, and we have built a complete medical system, or what we call like a primary healthcare module, for a couple of health ministries. And we are trying to see if we can get some access to small pilots, which we could try it out for the NHS context. So my question was just to understand if is that kind of an opportunity, like Hassan was mentioning, that there are too many companies trying to do that, but yes, there are good ones. How to identify that? And can we be part of that kind of a system where we are noticed?
So, and Rachel has unmuted herself, so I'm going to go to Rachel. And if any other member of the panel wants to comment on any of those three, Hassan does too. So Rachel first and then Hassan.
Yes, so the whole system piece within the ICSs, I am seeing change. I've experienced change. I've seen a set of situations where what would have taken a year or a year and a half to change in a commissioning cycle has been done in a week or two. And so, yes, I am hopeful, but equally not everyone's an ICS. And I've done some conceptual work with the Good Governance Institute about dynamic arbitration, because how do you work in a system where something is logically the right thing to do, but the organizational bounds of commissioner and benefit and so on are not aligned with that happening? And I think it's quite interesting to look at whether we could get to a dynamic arbitration model. That's something that I think is worth considering. From my perspective, we do need to change the cadence and the model of governance. Yeah, if we are going to evolve rapidly and safely with evidence, we cannot keep the governance systems that we have in place today. That's my conclusion. And I think one thing that COVID probably will tell us in terms of the pace at which we have had to change is that there is a different form of governance needed. So that's my perspective.
Rachel, can I just on the governance point?
Yes.
Is that, I don't think anybody seriously would argue that governance works currently, but are you, do you think the ICS model that's being developed helps with these issues? Are we going down the right path, or are there lessons that we need to learn that look beyond the ICS model that was developed over the last 2 or 3 years?
So my experience within ICS was very conducive in Salford. We were seeing, for instance, money out of surgical budgets being put into social care for interventions there within a week. That would have taken a whole commissioning cycle of a year and a bit previously to try and negotiate these things. So yes, it is, but what I'm alluding to is probably the wider systemic governance. And I think that the view that we have is that we have to see everything coming in the front windscreen. We do not delegate enough authority to see things in the rearview mirror, and many boards are once a month or every 2 months, and we have to see things coming, so we delay our ability to change. I think we need to be smarter about what we govern as delegated authority, what we govern. And when we do change management, technically we do emergency changes because there's something compelling that we need to meet. The sense that a governance cadence is every 2 months and that is that, I think is probably not fit for purpose for the future. So I think we need to reimagine the governance and the idea of arbitration or those sorts of things which we're seeing in other areas of government and other public systems. For me, a combination of that and the ICS is very compelling about how we move forward.
Okay, thank you. Hassan wants to come in. So does Sam. So Hassan and Nicola, do you want to come in on this round, or can I bring you in the next one?
I would like. I've got a point
Okay,
I'd like
fine.
to make on that I think is relevant to this one, if that's okay. Thank you.
Fine. Okay. So Hassan, Sam, and then Nicola.
Thank you, Stephen. So some quick responses. First to Guy, there has been change. It's been admirable what we've seen in social care, but it's not going to be quick enough to save lives because social care and the care sector is a new front line in COVID-19. You'll be aware of that because of initiatives around PPE, such as Kit for Carers. So if you can tell right now that there needs to be change, the gap is for someone entrepreneurial to try and fill that gap and work with the NHS and the care sector to stitch it together. And I think, Guy, you've got that idea already, and I do support you. For Suzanne, digital inclusion and exclusion is a focus of the system. Lots of people are saying that, empower the citizen, empower the person. But I personally haven't found enough digital solutions that really focus on it. And my interest is to support British companies to export and foreign firms to invest in the UK. And when I do find those companies, I really focus on them because it has to be, as Sam was talking about, democratizing this for everybody. So I think there's more work to be done. On Nishant's question about how do we find those gems, the truth is that we need to be very clear with you about the evidence requirements and how we need companies to find in-year savings, because we need to make sure that we have a sustainable system, and money is a big pressure for us. And a big part of the mission that Nicola spoke about for Tech for CV19 is to support, with an online community and an assessment engine, firms like yours to come and say, this is my offer, and we can assess that. And that's why I really strongly suggest you and others get involved with Tech for CV19. Thank you, Stephen.
Thank you very much, Sam.
So Nicola mentioned a point earlier about safety, and Rachel, of course, just discussed governance, and the two are completely intrinsically related, because that governance that exists at a system level filters its way down ultimately for the safety of citizens and for the protection of services that we offer to our population. And so we do need to think about this really carefully. And Andrew Fenton has raised a particular question about what is remote consultation in effect, and the use of things like WhatsApp. And I think this is where we need to do more to help educate and help modify the behaviors of our decision makers at a system level about what's important for citizens and clinicians at that interaction. Because if we are going to deploy safe care in a well-governed system, we need to take this more seriously and put more focus and effort into how we deploy solutions that are well-governed and that are safe. And good examples of this are clinicians and their patients as citizens will do whatever they think is right to solve a problem, to meet a clinical need. But in that governed system, we may not have decision makers that understand why we can't use products that may not be regulated, for example, like WhatsApp or others. And there may be other products out there that are completely safe, that can work in a well-governed system, that would meet the needs of both individuals. And so we do need to do something at that system level where we've got heterogeneous population that have different needs to make sure the range of products and services that might exist both in the UK and globally can be deployed safely to meet that need.
Great. And Nicola?
Yeah, I think it goes on quite nice from that point. What I wanted to identify was that my practical experience of dealing with information, managing information, creating insight and analytics from that information is how difficult it is to get both sponsorship and actually the integrations that you really need to be able to do that at a system level. And there are a couple of inhibitors, systemic inhibitors that I think are a problem for us. The first one is that generally most individual component organizations within an integrated care system, and as Rachel points out, it will depend on the maturity of that integrated care system, but the majority of them are still being held accountable to their own performance and therefore are preoccupied with information that can demonstrate and justify and can be used to scrutinize their performance. So the efforts are primarily put there, not necessarily into whole system information. The second thing is that as a result of that, and a result of a focus on technology being a means to service efficiency and process efficiency, quite a lot of our systems are not as well data designed as they should be. So alongside them being co-designed, they need to be designed with what data is this system going to facilitate for the benefit of the whole system. And that is rarely a consideration. What I see often when I join a new organisation is that there could be some really great tech going on in there, but the data team are being come to right at the end to go, what bits of data do you want? Oh, we'll tweak that field, we'll tweak that data entity. That's quite frankly just not good enough. And so I'm thinking about, on top of what we do around governance, what we do around support from industry and how we think that way in the business context of this, I think there is also a role for CIOs and CDIOs. And I think our role is to look at whole system modeling, and we need to start looking at the new types of enterprise modeling. And I particularly urge people to look at the work of the Global University Alliance. They are doing some real cutting edge stuff around enterprise modeling. And I think that that is a approach that might help us start to look at the system as a whole. And it's the contribution that I think CIOs and CDIOs can bring to the table.
It's an important point, Nicola, because it's no good talking about ICSs and joined up public service systems if you don't build it on joined up information flows. Totally. It's the digital connection is what creates the integrated service. Yeah. And that, I guess, is a point that Tim Hubbard wants to make. I'm just conscious that there's a message at the bottom of my screen saying that there are 50 messages that haven't been addressed yet in this conversation, which suggests in the fashion of the times that the R value is a lot higher than is going to be. It means we're not going to get to the end of this conversation and answer all of those points. But so what I suggest we do is take 5 contributions and then leave it open to, well, no, in fact, I tell you what I'm going to do is just keep going down contributions from attendees, watching the panel members and pulling them in if they unmute themselves, but seeking to get several people from the body of the care, as it were, going. So Tim Hubbard first, and then Duncan Claxon, please.
Oh, yes. So this question about, can you use something like NHS app as an integration to solve this problem of an infinite number of providers, particularly people brought on for tactical reasons, where they're just not integrated, and they're also trying to keep the data. And even if you brought those on, basically say, well, if we're going to keep it, you have to integrate with the NHS app, and you have to sign agreements around data flows as well. And that become a vehicle for making a better UI experience for patients and joining up the data as well automatically.
Thank you, Tim. Duncan. And after Duncan, I'm going to ask Vincent Buscemi and Andrew Catlin.
My own experience at our hospital, which is a private hospital, is that we mainly treat insured and self-funding patients with very small spot contracts for the NHS, where they're otherwise inundated. We'd already began a journey of telehealth, but it was undergoing the extensive due diligence, which is normal when you belong to a larger corporate, which we do, more specifically Bupa. What was interesting is that we were able to bring this forward by a considerable amount of time in light of COVID-19. And we have, of course, are one of the 4 cancer hubs in London, which are treating NHS patients amongst others. I don't see the need for, I think what we're worried about is the speed of change in the technology in the time that we're undergoing the due diligence, and already we're seeing platforms which are doing more with less. And it's just whether we've married now to the right supplier to be able to continue that relationship. But certainly to attract medical inbound tourism, it will be super beneficial in that we feel that we can best advise people before who are otherwise flying to have their outpatient appointment and diagnostics at the hospital. And it could be that we need to tell them either to fly sooner because of the results they already have, or that there's no need for them to travel at all in light of what we would call a second opinion.
Thank you. Vincent.
Thank you, Stephen. Yes, Vincent Buscemi from Bevan Britain. The point I was making really goes right back to the point that Hassan was making at the very beginning of the session around the noise in the system, and the concern that I've heard from contacts and clients on both the provider operator side, but also on the digital supplier side, in terms of the difficulties that the providers and operators are having around separating what are the good, bad, and indifferent products and services that are now out on the market, and the approaches that they're having, effectively being inundated with offers to help. Now, on social care, a number of the operators I've spoken to and work with, they've brought forward their digital plan, as it were, by in some cases many years, and have adopted technologies which are being offered to them because they are a solution to a problem that they have at the moment. Their concerns much more around the fact that in normal times, they would treat this as a full sort of change management process, not simply an IT project that gets rolled out. But they've had to embrace that technology pretty quickly in a less than optimal environment. And their concerns around, are these things safe? Are they effective? What happens when we get over the initial COVID response issues and we move into, whatever the new normal looks like? Will us as operators and our staff have gotten used to this, but then the suppliers either take this stuff away from us or say, we'll only continue to support it if you pay significant sums of money above and beyond the fact that maybe they were offered these at a hugely discounted rate, or even in some cases free. So I think it's an opportunity for the digital community to embrace these opportunities, but I think there's a lot that needs to be done to help the operators through the process, both now, but also when we get out of the current lockdown type situation.
And Andrew.
Yeah, thanks, Stephen. Couple of points, picking up on some of the digital mental health stuff, just to let panelists and other people listening about some of the work collectively that we at Dr. Link and other digital providers have been doing for London with the Good Thinking. And in the period of time we've been working, we've been helping over 220,000 Londoners with their mental health well-being issues. So I see digital as being an enabler around mental health. I agree with many of the panelists, it is not a panacea, and you do need to have a mixed approach to how you resolve many of those issues. But the other point I wanted to just quickly touch on, Stephen, was there's so much frenetic activity going on, certainly in primary healthcare and in CCGs around COVID, that they are drowning. And to give you an example, a significant amount of funding has been earmarked by NHS England to support those CCGs that have not as yet got a digital front door. And that framework has been running now for 3 weeks, and there's hardly been any drawdown from any CCGs in relation to that funding. I think they're just drowning under COVID-19.
Yeah, I think that's a story we've heard before. Steve Gardner has indicated he'd like to come in.
Thanks, Stephen. I don't want to speak particularly to Vincent's point, but also to what Andrew was just saying. I think I guess you know me well enough to know that I could probably be fairly described as a baldly commercial individual. That's fair to say. What concerns me slightly in the current circumstances, and those that I've spoken to in the last few days probably agree with this, the issue around providing stuff at low cost or free as a result of, as a reaction to the current crisis, I think is short-sighted. And the reason why I say that is quite simply because there's no such thing as free. If I give you something for free, I'm paying for it. It's my resources, my time, my IP, etc., which all has value. The only way of dealing with what we're doing now, with what we're dealing with now, is to build sensible, profitable commercial models, because what that does is it supports the sustainability of the solutions we're trying to put forward and ensures that we develop and evolve new ones. You can't do that if you're trying to do something for free. You can't keep the lights on. I think the other point that I think sort of comes off of this, and also speaks to Andrew's point about organisations that are drowning in the current crisis, is the fact that thinking about what we can do immediately right now is kind of not helping. You know, because at the end of the day, the fact of the matter is, particularly in the UK, we are landed with a procurement system with a situation where things will take time to be brought on stream, to be implemented. And by the time we've done all of that, this current wave of what we're dealing with COVID will be over or coming to its end. We'll be starting to come out of lockdown. I think the question I would like to fire back to everybody is simply this: should we not right now be thinking about the next wave that we all know is coming? You know, we've seen the Harvard reports talking about this is going to be with us for 2-3 years. We've heard Chris Whitty talking about a second wave is coming. Surely what we should be doing now is thinking about what, from a digital perspective, we can implement now that will help deal with that next wave, because that's what stops us potentially from drowning in the future.
Okay, and Hassan and Rachel both want to come in as well.
Thank you, Stephen. I'll give a quick response to what Steve was saying, and this touches on some other questions that have been asked. We do need to move quickly, but in a specific way. We need to find the solutions that are validated and evidence-based and accelerate them quickly, rather than start from scratch, find something that looks really cool and shiny and flashy, and then push it forward because of its brand. And typically those are the ones that have those odd commercial models. A bit like trying to offer you something, as you said, Steve, for free when it's not really. They get massive market share, distort the market, and no one knows what's going to happen afterwards. What we need to do is find those solid companies with great evidence, great relationships, great case studies, reference sites, where CIOs like Nicola and Rachel would say to me privately, look, they did a good job for me. I like them. They're the kind of guys that we need more of. And those are the ones I want to promote, both for investment and for trade.
Rachel.
Yes, thank you for that. Referenceability is very, very important. And, you know, I think that's where we need to move forward with solutions that have been incubated within the NHS and make them move wider. I am an optimist, and for those that have been tactical, I don't recommend it, as in, you know, extremely tactical, taking free things and just forcing them in. But actually some good will come out of that, in terms of the fact that I think we will get to a space where people will come to review what this means systemically. That has to happen. And just to be very clear, we need to design systemically, as Nicola said. So, you know, what you put in one side of the system to collect data with the patient or about the patient could appear in another part of the system in a different context for them. So we have to think about what we are doing and how it systemically fits. I think that will come, but for those people that have really just picked things up and thrown it against the wall and seen if it will stick, rightly or wrongly, at least people have now got a frame of reference of what has or hasn't worked. At least people have now got some evidence and an ability to articulate. We're sharing language, frames of reference around digital. And so the optimist in me says, even though they've done things that, you know, personally, I probably wouldn't have done myself, I think it will allow a reference point for that systemic design for the future. And hopefully some benefit has come out of it as well. We do have those risks commercially about embedding things where we don't have a longevity and partnership with the supplier. And what I would say is that, you know, whatever I do, I regard the work that I do as a CIO, when I am a CIO, as being in partnership with suppliers. Part of my procurement is not just about the technology solution, it's about a meeting of minds and the ability to move forward. And indeed, when I do procure, it's not just about technology today, it's about the aspiration moving forward. And so if there's anyone in this sort of, WebEx or who feels that they are moving forward, please don't just consider the solution, consider who you are working with and why.
Could I'm going to go to Simon Swift now, who I think has a question around sort of the openness of the system to work with people, with new people. Simon, would you like to make your point?
Hi, Stephen. Thank you for bringing me in. So I'm seeing two very polar opposite sets of behaviour at the moment. One is people behaving in a way that is outside of the normal procurement processes, without necessarily the due diligence that is normally in place in order to do something very fast. And yes, things need doing very fast, but they need to be done openly, fairly, and transparently. The other thing I'm seeing is, as has been alluded to, there are people in the commercial market who are putting in sort of light offers that are available now, but they don't know when those will terminate, or they're trying to, tie people in for long term, which is not necessarily going to offer value. So the people who need the services have become very defensive and are basically saying, look, we're not going to talk to anybody because it's the Wild West out there and people are behaving outrageously, so you can all go away. How can we put in place at all levels something that is rapid, fair, and transparent, so that those of us who try and offer value, who understand governance, who understand the system, and have things that we believe can make a difference to both citizens and the system, can get airtime, while preventing inappropriate behaviour and decisions on both sides of the supplier and buyer side. I think I got there in the end.
Thank you, Simon. Nicola wants to come in, and Sam Shah has also been commenting on this on the chat. So can I bring in Nicola and then Sam, and then I suggest we move on to some of the other service issues rather than just this issue that I think we've explored reasonably well. So Nicola, then Sam.
I'm going to keep it fairly short, but I am also going to use it as an opportunity to blatantly promote what we're trying to do in the Tech for CV19 community, if you don't mind. Completely agree and understand with all the points that you are saying, Simon, and it is a frequent point of discussion, we note, across the community, not just by the founders of the community, but actually the people that are engaging with it. The expectations and the purpose of the community is to be there to deliver solutions for the system as a whole. And we've been working on principles, and these are draft principles, which will be going out to consultation, but I think they may give you an understanding of where the match is. We're looking at inclusivity for learning, equity for equality, collaboration for competition, ecosystem for value, peer-to-peer for partnership, and community for the whole system. And for these reasons, those of us that are part of Tech for CV19 want to be part of those discussions and support those discussions about establishing appropriate, fair and effective solutions for a system as a whole. And I think that draws on looking to work in the way that Rachel said, she likes to work as a CIO. It's how I like to work as a CIO. And my experience is that where I have had transformations, changes, deliverables that I have been very proud of and I have felt have been truly effective, they all have one common theme, which is that partnership approach.
Thank you, Sam.
So there probably isn't very much more to add on this, other than I completely agree with Simon's point, actually, that he raised in the question. What I would say is that the maturity amongst decision makers in the system has changed. And so if I go back 5 years, 6 years, when we were first sort of engaging in the health tech market, it was much narrower in terms of how things happened, and decisions, you're quite right, were happening much more rapidly with perhaps much grayer procurement processes. But that partnership approach, that relational sort of model of contracting is evolving, not in every part of government, but in some. And I think initiatives that Nicola's leading on, things that Rachel's doing with the Academy, is changing the type of people that are coming into the system. And I certainly know other fora that Hassan is putting together is creating that dialogue where people can have that discussion in a much more open way. But I would agree there needs to be some way of creating some sort of communities of interest in the health system that help CIOs, CDOs, and actually anyone in the system engage with counterparts in industry to work in that partnership model, coming up with use cases, understanding users, sharing user experiences, and working out solutions that can match those user needs, and then to try and share what evidence takes place is evolving so that it's not repeated, but we can more rapidly implement solutions rather than asking the same questions again and again. But Simon's point is well made, and most people that know me know that I quite openly discuss the fact that we do need a different type of maturity model in commissioning around digital health.
Okay, that's great. Can I suggest we move on? I want to try and bring in a more international element to the conversation. I think we've become perhaps a little bit too focused on NHS process at the moment. And Peter Yang is suggesting that we have something to learn from the Far East. Peter, if you're still on the call, could I ask you to make your point?
Okay. Thank you, everyone. I just experienced, because now I'm helped a lot of foreign government authority to purchase some PPE goods from China and also from Taiwan as well. So I know, like China, they use the APP for everyone installed on the APP. They know what kind of people they are extremely healthy. There's a green line on the mobile phone. If someone they move to some infection zone like Wuhan or some other city, they could be red or could be yellow, and even so that will help the government authority or even the public. They are aware where's the place have a high risk for infection, so that control the population movement. I think that's the one successful experience. So that's why they can control that. And also they develop some kind of they call it anti-epidemic machine, put it in some public building or public space. When the people they went through, if they have some fever, and they immediately have some message, so this person need to be isolated or put in some hospital. So they have some kind of digital health solution to control that. In Taiwan, at this moment, I know they created some APP, because now they try to keep people have some kind of social distance. Everybody, they have a mobile phone. They just switch on the Bluetooth. If the two people getting too close, maybe within the 1 meter, that kind of distance, if one of them have some kind of infection, immediately the other people, the mobile phone have get some message or some kind of vibration to show, okay, you need to keep distance. So that's some way to government or some company and also healthcare work together to use the digital health technology to prevent public health and safety. I think that it won't cost a lot of money, but it's really, really helpful for people who understand where's the risk, and then they can take more responsibility for themselves to get that kind of, protection for themselves. I think that's something maybe in the future, maybe like Stephen, your journal maybe can do some kind of special report about it. I think that more people aware that kind of successful experience. Yeah.
Thank you, Peter. Well, Steve Gardner is listening and no doubt making notes. So thank you for that. I also want to bring in, hoping that he's on the call, Dimitri Varsamis, who works in NHS England and who wrote in ahead of the call, making some points about the financing of these digital solutions, in particular in some in some of the less rich countries in the world. Dimitri.
Yes, can you hear me? Yes, I think you can.
Indeed.
So indeed, thinking more internationally, in terms of who paid for those new digital solutions in different models internationally, for example, in sort of fee-for-service settings, and indeed in employer-based health insurance places, even the US, let alone lower middle-income countries, primary care physicians are struggling to stay afloat because of fixed costs, such as rent, while they're facing reduced activity, and then suddenly increased costs for telehealth solutions. Now, how would you go about, any member of the panel can answer that, financing digital solutions, less within the NHS, but in a sort of mixed economy, healthcare funding models of part public, part mandatory health insurance, part private health insurance, a mixed bag, which is frankly most of the world. And the UK is not excluded per se either in some ways, because 20% of expenditure here in healthcare is a private, either out of pocket or private health insurance.
Okay, Dimitri, thank you. And panelists who wanted to come in, but I want to bring in Paul Johnson as well, who refers to some data from other parts of the world about the use of digital technology in improving readiness for pandemic. Paul.
Hello, can you hear me okay?
We can.
Good, good. I mean, some of it was picking up from the session with Dr. Charles Alesi, where it occurred to me that some of the problems we're experiencing is that we just don't have that precedent. And so we were woefully unprepared. And I say that we, as every entity across the healthcare sector. And he gave reference to, I think it was Taiwan, Saudis, and South Korea, in terms of he'd visited those areas and they were very well prepared and very much underpinned by technology and that digital capability. And I think we've seen that in the results that they've achieved. So clearly there has been some best practice that we could adopt. And I just wondered, how do we actually go about translating their success that they had and the lessons that they've learned, because they were obviously affected more than we were by MERS and SARS, and hence that drove that preparation around that. And certainly from our perspective, we work with Ministry of Health and Prevention in Dubai, likes of Cleveland Clinic, people like this, where they very much see that digital technology to underpin the best practice. So they identify the best practice first, and then align the technology to underpin that. So it was more, how do we take those lessons learned and translate them?
And I think Keith Davis is apparently having no luck from waving his hand. I apologize for that, Keith, but your message did get through in the end. If you're still on, would you like to make your point as well? Similar theme.
Oh, can you hear me?
We can.
Ah, thank goodness for that. Thank you very much, Stephen. Yes, I was noting there in the box, in a sense, repeating what the last intervention was. That the Saudis seem to have got their act together extremely well. I was very impressed by the conference that Charles Alesi held about a week ago, where he had people from not just the Ministry of Health, but from some of the key trusts there. And they have brought on stream a fair number of things that I think we could learn from. The conference is available online anyway, if anyone is interested in it. But we can learn so much from a culture in the Middle East that gave us, what, 1,000 years ago, quarantine, which then the Italians claimed as their own. So there's a lot to learn from the ancient cultures of this world. They're moving ahead of us. Thank you.
Keith, thank you very much. I'm conscious that we've only 10 minutes left now in the time allocated. So I'm going to go one by one round the panel and ask for some closing comments, wrapping up those contributions that we've just had into those closing comments, please. And Rachel's unmuted herself. So can I go to Rachel first, then Hassan? Thank you.
Yes, so some excellent points there, but I have calls 3 times a week with Saudi, and my perspective is they don't have any different technology to us, but what they do have is different rules. We have GDPR, and I am quite aware of what they're doing. I've also been asked to peer review and have been involved in 3 other apps for contact tracing, another one from the Middle East. That nation has decided to put its oil money into expediting digital health. So they have huge amounts of money and an aspiration for when we get out of the fossil fuel world, that they will be a digital health global leader. And another 2 nations, one of which does have GDPR, and again, it has to be a different approach. So yes, there's global learning, and digital health research globally is my specialty in research. We do need to share these stories, but we do also need to acknowledge the very different baselines that all of these nations come from, both in terms of rules, regulations, legislation, financing. And I would say that Saudi has done some pretty amazing things, as have other nations, but I think we need to examine and take the lessons learned at the end of this from different nations. And indeed, we may need to change legislation globally to make sure that we can actually, step up in times of crisis, because it may be stopping us having an appropriate response.
That's the important point, isn't it, Rachel, that we should look at what other countries have been able to achieve.
Yes.
And of course, that doesn't mean we have to adopt all we wouldn't want Chinese systems of government or Saudi systems of government blindingly, obviously. But we should ask ourselves whether they've achieved outcomes that we could achieve by different means, but by learning by their experience as well.
Absolutely. It's a judgment. It's a judgment with, around how much we want to pay in taxes. It's a judgment around how much we value freedom versus, the greater good. That there's various trade-offs and judgments we need to make, and that will vary society by society, I suspect.
Indeed. Hassan.
Thank you. I feel like the opportunity, and it is terrible talking about opportunity in the midst of this tragedy, the opportunity is for us to take technology into its right place. And its right place is front and center to support care, not waiting for people to get sick, predicting what's going to happen before they come in, dealing with them virtually. And we have a problem in this country where we don't realize the value that other countries put on our technology and our heritage. Whenever a British company goes abroad, and Steve Gardner will know this from his work with the World Healthcare Journal abroad, whenever anyone sees it's British tech, they're interested, they think about our heritage and our track record of scientific discovery. So we have a great advantage, but we need to help those companies that we get in this country to get scale and adoption. So we have to marry that together, and then we'll be able to take this technology to places that need it. And sure, there's no arrogance on our side. We will learn from Singapore and other countries that have done very well in the crisis. But once bitten, twice shy. We will be ready the next time.
Well, I hope you're right. We should, the truth is, history never repeats itself. What we'll probably make is a different set of mistakes. But anyway, so Sam Sam's unmuted himself. Then I'm going to go to Nicola, and I'm going to conclude with Steve. So Sam, please.
Global pandemic has had multiple impacts, and putting the current situation aside, we do need to speak to our partners in other countries to understand, as you rightly said, the outcomes they've achieved and what the impact has been on reducing health inequalities and inequalities in society, because those things are of course important to us in our society. But to do that, we need to measure and value data that will help us to understand what those outcomes are and what has been achieved in terms of reducing inequalities and the inequity in access to services. So it's not just about the technology, but more importantly about what we achieve for citizens. And we have to start off with citizens. There are 3 needs: their clinical need, their emotional need, and their practical need. And that has to be our starting point not really the technology. And we hope that, of course, the technology will come to help us solve some of those needs that citizens present with. But we have to be willing to be open and speak to our partners around the world. And we can't lift and shift technology, but work out what a local application of that technology would be in order to achieve a similar or better outcome.
Thank you. Nicola.
Yes, I think there's it's an interesting journey when you start to look at how healthcare systems are working outside of the UK. We are particularly unique. We have one almost historic institution when you think about the age of the NHS, and it is not necessarily the same as what you find elsewhere. And I think there is opportunity for learning both ways. When I've had the chance to go on study tours in Europe, I think the areas that I've been particularly interested in have been Scandinavia and the Baltics. But I always have to remember that their care systems are different. They are totally integrated. They don't have the separation of commissioning that we have. They have a single point of governance, and that does help their decision making. Plus, they are not as large communities, nationalities in terms of populations. They are very good at co-design and working with their not just clinicians, but actually truly working with citizens. And I think for me, going back on some of the points that have been made early, I think we really need to self-reflect when we talk about co-design, whether we are just ticking the box and we have a patient representative at the table, or whether we are truly working with citizens or thinking what it's like to be a citizen in this system when it comes to how we redesign the system as a whole. Thank you.
Okay, thank you very much. Steve.
Thanks. I think for me, my reflection here is that, you know, not just in this discussion, but in the conversations that I had with numerous individuals, both in the audience, on the panel, etc., etc. I think the panel's been absolutely fantastic. But what really comes across to me is that I am very, very proud to feel like that I'm part of this UK digital health community. I've worked in 30 odd different countries around the world with Healthcare UK and through the World Healthcare Journal. And I say this with absolute sincerity that I genuinely believe that the UK has the best digital health sector in the world. We have the best innovations. We have the best ideas. We've got some fantastic stuff. And really the key outcome of this that I'd like to see is that we don't just stop here, that we don't just have this debate, that we don't. Tech for CV19 has been a brilliant innovation. Thanks to Rachel, Hassan, Nicola for organising and creating that forum. But I think now it's about how we take that fantastic community and group and take our sector and move it forward. And I know I've spoken to a number of you in the audience and the panel over the last few days about the idea of how we do move this forward. And you know, what I would encourage is what we want to do with the World Healthcare Journal in partnership with PPP and others is create a report, a white paper that we as a sector can come together and make some recommendations to our own government around some of those issues that Sam and Rachel talked around governance, around some of those things that Nicola's talked about how we glue things together. And also, as well as making recommendations from the digital sector to our own government, this is not just a UK problem. How do we, you know, it's a global problem. So we need to be pushing the UK digital sector, not just to our own government, but to governments around the world. And for those of you who I've not already spoken to, those of you interested in getting involved in helping us to shape that report, please do get in touch with me. But fantastic debate, guys, and thank you all so much.
Can I just say in conclusion, to echo what Steve just said, thank you in particular to the 4 external panel members. It's been a privilege for us in World Healthcare Journal to be able to coordinate this. Grateful for that opportunity. The whole point of the World Healthcare Journal is that in reality, although systems are different, healthcare problems are largely the same, and there's a high degree of a shared agenda around the world. And I agree entirely with Steve. that's an opportunity for us in the UK. Whatever your views on Brexit, post-Brexit, one of the areas where the UK has an urgent need as well as an opportunity is to invest in the development of health and life science, the development of the UK as a centre of expertise in health and life sciences. And the digital health sector has an absolutely key part to play in that process. So that's a theme that we shall be following up through World Healthcare Journal. And I also, to those on the chat who are looking for a meeting place for sharing ideas around these themes, that is, of course, precisely the point of Tech for CV19, the forum that's been coordinated by Nicola and Rachel. That's we're grateful for the opportunity of working with you and hope to be able to continue to do so in the future. I notice Nicola has unmuted herself, which has been the symbol through the conversation that she wants to say something in conclusion as well. So, Nicola.
I've actually unmuted myself by accident, Stephen. I'm very sorry. But thank you very much for the opportunity, and thank you very much for promoting what we are trying to do across this community, which is creating a place where people can come and debate and continue the sorts of conversations we've been having for the last hour and a half. Somebody's raised in the chat that, you know, at the end of the day, this is a very complex system. It's very complicated, and it's a very complex system in terms of human beings. And I think it'll need a lot of us with our experiences and our capabilities and our thinking to come together to look at how we move things forward for the better.
Thank you very much. I think at that point, I'm going to draw proceedings to a close. Thank you to Dan as well for coordinating at a technical level. Thank you very much, one and all, and meet soon. Thank you.